As far as blepharitis and Meibomian gland disease, and we've talked about aqueous deficient disease, whether it's a lacrimal gland problem for dry eye or a Meibomian gland problem with Meibom problems, it's all goes to the tear layer. And having one that's abnormal will make a patient have a poor tear layer. And so this ocular surface disease is really dry eye Meibomian gland disease. So we never separate them. In fact, all patients have some form of both of these findings. And looking at this, see the prevalence of patients who have Meibomian gland dysfunction or blepharitis, depending on your terminology. And we're mostly looking at the posterior segment, the Meibomian glands. So there was a study of 100 patients preparing for cataract surgery, which we are part of that study. And the prevalence of people just walking in for cataract surgery is about 59% of patients had this disease. Another group of patients, 50 of them with macular degeneration in that study, there were about 93% had signs of Meibomian gland disease. Again, it's across the board. We're not just looking at external disease patients. In Singapore, a study showed that 56% of patients mid-age range of 40 to 80 years old had Meibomian gland dysfunction signs and symptoms. And a Spanish study of about 1,200 patients, a good 30% of these people had Meibomian gland dysfunction, both symptomatic or asymptomatic. So there's a big scattering between 30% and 90-something% on how people rate this disease, but it's prevalent and should be looked for because it leads to problems. And so the Meibomian gland, which is something we've made a living in after the last 20 years, are very important in ocular health and disease in the eye. And that's because the Meibomian glands produce this great oil, or chapstick, so to speak, to keep the eye hydrated and moist and in a good functioning layer. It stabilizes the tear film, and as all of us know, when we were going through residency, the most important refracting surface of the eye is the tear film. And if the tear film is not of good quality, then patients don't see well. Postoperative results, whether it's refractive or cataract or refractive cataract surgery, cannot do as well as we or they would like. The Meibomian glands produce this oil which stops evaporation and keeps a good ocular surface. But not all Meibomian gland disease is obvious. Certainly if patients come in with collarettes and scaling and scurf, you can see that. But sometimes, if you look up on the board, there's a pretty clean lid, and if you squeeze very hard, nothing comes out. We call this non-obvious Meibomian gland dysfunction. And so squeezing with a finger or a Q-tip and looking at what comes out, I would challenge you to say that these are normal secretions. They're not. They're toothpaste-like, gelatinous, and really non-functional, so to speak. And when talking about eyelid disease, and again, there's separators and lumpers, we kind of lump together, but really blepharitis has an anterior component, as seen on the top slide right, where there's crusting and scaling of the lashes, but also posterior disease, where there's abnormality of the secretions from the Meibomian glands. And they're mixed, but I would tell you this Venn diagram should be much more mixed. I think everyone has some components. And again, signs of anterior blepharitis would be scaling, collarettes, cylindrical dandruff, and just crusting, or what we used to call scurf. And signs of posterior blepharitis, when you look at the glands, surface-wise, you can see it's this foaming, which is due to the lipase activity of the bacteria. But you will get thickened secretions, diminished secretions, gelatinous, purulent. And we grade these secretions because as you treat, the secretions will improve in both volume and in consistency. You've seen some clinical slides, and there's so many ways of looking at posterior meibomitis or Meibomian gland dysfunction. And when we see these patients, we're grading them and we're putting it into our record. And we're looking for many things. As the margins become thicker, they get telangiectatic vessels along the edges, they get notched lid margins. The lashes, because they live within the gland, which is now inflamed, you've heard that before already tonight, lashes get distichiasis, trichiasis, they just don't work well. Sometimes if you look at the lid margin, you'll start seeing a little raised edge line, a line of marks, which kind of becomes more retroplaced. The acini, if you flip the gland over and do photographs, become kind of shriveled and just go away. The orifices become smaller. They become, ectatic. They become pouting. They don't function as well. And the secretions become abnormal, both in volume and in quality. They lose that olive oil type quality and become more pussy. And I use that word a whole lot to patients. It's not infected, but it's inflamed.
The whole algorithm with treating ocular surface disease, to Gregg's point, is you want to treat patients early. You know, once they're clogged up and all keratinized, really nothing works sometimes when there's so much apoptosis and the glands have kind of degenerated fully. When you categorize all of ocular surface disease, there's tear underproduction, where we're commonly, the first step is using supplements like artificial tears. And then you could start going up to more viscous tears that have sodium hyaluronate in it, like Oasis or Blink. Preservative-free tears, because we know the preservative is also toxic to the surface, so avoiding preservative to allow the patient's SPK to heal. Sometimes we use, obviously, prescriptions like Restasis or even Xiidra, and we superdose them, sometimes even using more frequently than indicated on label. Autologous serum tears work wonderfully well, but they're not easily accessible. We've provided that in our office for a while, but then now the eye banks, some of the eye banks around the country are providing serum tears for patients at a cost. In secregogues, we have been in studies, and obviously there's a lot in clinical trials with dry eye. Tear supplements, Gregg mentioned using fish oils, and there's several oral supplements that are available. Restasis and Xiidra help the ocular surface, but they also help lid disease because they're treating the inflammation on the surface that makes the lid disease worse. And then we do tend to lump posterior and anterior together because a lot of the treatments will help both. But if it's posterior blepharitis, it's a problem in the way the body is making the oils. And so addressing that with warm compresses, treatments such as Avenova, the omega-3 supplements to make the oils more liquefied at a lower melting temperature. That's how oral macrolides like doxycycline or azithromycin help. Probing of the duct, unclogging the oil glands helps release all the old oils and getting that out really helps the patient, and using LipiFlow. On anterior blepharitis, we really want to calm down the inflammation. That's why we commonly will use steroids like Maxitrol or Tobradex ointment. Addressing Demodex and even vitamin ointment has been helpful in these types of patients.